So I'd like to introduce our speaker for today, Dr. Wintergerst. Dr. Wintergerst completed his pediatric residency at the University of Florida College of Medicine before completing his pediatric endocrinology fellowship at Stanford University. In 2006, he took a position in the Division of Pediatric Endocrinology at the University of Louisville, and later took over as division chief in 2014. While continuing to care for patients in the clinical setting, he maintains a strong interest in teaching, community service, public health, and clinical research, and holds several local, regional, and national leadership positions. His primary clinical and research focus is in the realm of diabetes, improving the lives of his patients, and eventually hoping to cure type 1 diabetes. He became the director of TrialNet Diabetes Studies in 2011, an international research consortium for the prevention of type 1 diabetes. He also became the director of type 1 diabetes exchange studies in 2015. In 2013, he was named director of the Wendy Novak Diabetes Center, the most comprehensive pediatric diabetes center in Kentucky, and became the Wendy Novak Endowed Chair of Pediatric Diabetes Care and Clinical Research. So Dr. Wintergerst, thank you for this lecture, and he's going to talk to us about the diagnosis and management of type 2 diabetes. So I'll turn it over to you.
Thank you very much, Dr. McDonald. Good afternoon, everyone. I very much appreciate the opportunity to talk about a topic near and dear to me, and I also appreciate everyone taking the time out of their day to learn a little bit more about type 2 diabetes. So I'll get started here. And so I have no personal financial interests. I am a principal investigator on a number of diabetes trials, as you heard from Dr. McDonald, and currently 2 of them are type 2 diabetes studies. And so today we'll talk a little bit about the pathophysiology of type 2, some diagnostic approaches for identifying type 2, and then some therapeutic options. And it'll be an array of diet, activity, and pharmacologic therapies we'll discuss. So first, a little about pathophysiology. And so there are more than 10 different forms of diabetes, and we tend to focus a lot on type 1 and type 2, although a number of the others have some characteristics that are interrelated. Type 1 is effectively the form of diabetes that results from the progressive destruction of the beta cells. So you cannot ultimately make sufficient insulin in order to meet the demands of the body. Type 2 is somewhat similar in that you do have progressive loss of beta cell secretory capacity, but there's that extra component of insulin resistance that plays a role. And so looking at that sort of stepping back a little bit, we have impaired insulin secretion because of dysfunction of these beta cells, that impaired insulin action, so secretion and action are both impaired through insulin resistance. What's interesting about the beta cells is they go through this evolutionary change, and this happens with quite a few of the endocrine glands in response to increasing demand, but they transform in an effort to increase the overall supply to the body. And so what you end up having is your insulin concentration is essentially increased relative to that severity of insulin resistance that it's trying to overcome. And so another feature that was not unknown prior to the genome-wide association studies, but because obviously we had a lot of information relating hereditary risk with diabetes, but what we found is more than 50 gene loci linked to type 2. So very high twin concordance rate, very high, 100%, and 84% have a close relative. And so if you have a first degree relative with type 2 diabetes, then you have a very high chance of also developing type 2. And so some things we talk about with families. And so I think this is, these couple of slides are helpful. But the first thing is they obviously often know that it runs in families because their parent or their grandparent or uncle or whatever might actually have type 2. And so we do speak to those genes. So that's the pink and the yellow circles on the right-hand side, where we know there are genes that are associated not just with beta cell dysfunction, which is more directly linked with type 2 diabetes, but it's also these adiposity genes that, and so it's one of the hallmark features, of course. And on the left-hand side is something that a lot of families don't think about, or we don't think about, and that's the environment. Now, this has changed. Anyone who's been in pediatrics for more than a couple of decades will remember that type 2 diabetes in pediatrics was actually quite rare. And so when I trained, in general, you only had a handful of children, all teenagers, that had type 2 diabetes. And now, out of 1,800 children and young adults up to age 26 that we serve here at the Wendy Novak Diabetes Center, we have nearly 10% of those have type 2 diabetes. So it's pretty dramatic. And that's, we think, because of the environment. So we have more sedentary lifestyle, increased caloric intake, and decreased nutrient expenditure. The next thing we look at, though, is when I'm teaching families, is I try to keep it relatively simple. And on the right-hand side, you see that square box that looks at some of those features that we connect with type 2 diabetes, and the two major factors, insulin resistance and beta cell dysfunction. And so I talk to the families about what is happening in the body. Your body is trying to produce more insulin, and it is fighting against this resistance. And what you have is increased liver production, hepatic glucose production, and increased or reduced uptake from the muscles. And so the net effect is a higher glucose in the system. You also have an increase in fatty acid production. Now, we endocrinologists like to appear edgy, and so this is making it look like endocrinology is a more dangerous profession. And so we have moved on to this ominous octet. And so one of the things I like to share this slide is that it actually points to the targets that we have now really focused on in the world as far as efforts to create pharmacologic options for our patients with type 2 diabetes. And so, just running around the entire circle, you see some of those that we just discussed: decreased insulin secretion, increased hepatic glucose production. Some other features, you have islet cells. How do you influence the excessive glucagon secretion or the decreased incretin effect in the intestines? What about the kidneys, where they have an increase in glucose reabsorption? How do you possibly influence that process so that the kidneys do not actually reabsorb so much glucose when in fact you are hyperglycemic? And so we will get to talk about that a little bit later. So diagnosis. So who to screen? So I shared this. This is from Diabetes Care in 2018, and this reflects a risk-based screening approach for type 2. And so one of the things that we, of course, would recommend is that if you have patients that are greater than or equal to the 85th percentile or the 95th percentile, effectively overweight or obese, those youth should be considered for screening for type 2 diabetes. You'll see some other features that have either a very high or moderate strength from the data linking risk factors, but maternal history of diabetes or gestational diabetes, family history of type 2 diabetes in a first or second degree relative, as I mentioned before, that is very high. The next one is actually not as high as we had previously had thought. And that is because of some ascertainment bias. And so we've talked over the last several years about health care disparities, health inequities, and this racial or ethnic association with type 2 diabetes, frankly, is not sufficient to warrant particularly looking at those populations. So if you have a Caucasian child who is obese and they have a relative with type 2 diabetes, obviously that's very high. But if they are simply obese, then a consideration should be made to screen them for type 2 diabetes. It should not just be those particular racial or ethnic groups. Signs of insulin resistance are a little bit more subjective, so acanthosis nigricans, or other features that point us in a little bit more in the direction of metabolic syndrome. All of those are features that should increase your thoughts of screening for type 2. And so how do we do that? From a cost-effective standpoint, doing a fasting blood glucose is the most cost-effective. In fact, even using a glucometer in your practice is probably the most cost-effective. However, it is not quite as sensitive. And so when we consider the best modalities, I like to do a hemoglobin A1C along with a blood draw glucose, RFP, BMP, whatever it might be, preferably a CMP in order to look at liver function and renal function. But with that, you can correlate those two together. And while that says fasting, I like to utilize the captive audience approach. And so I would recommend, it does not matter whether they are fasting or not, go ahead and draw the blood. It is helpful to log what food they've eaten and document that in the chart so that you can go back to it and determine whether they've had a significant carb load or not. And it is helpful to try to use that to determine what the values mean. And I'll go over, this next slide will be helpful for that. But a 2-hour oral glucose tolerance test is what we consider to be the gold standard. And we do use 1.75 grams per kg up to a maximum of 75. And we like glucola. You'll read reports about using jelly beans and other agents. But frankly, those are inconsistent. And so I would recommend glucola. And so when we look at our diagnostic criteria, a lot of times we think of these as sort of lines in the sand. And so I think it's valuable to look at them in together, but also in isolation. So what I mean by that is if you have an A1C of 6.8%, but you have a glucose value that's a fasting glucose of 105, or sorry, 95, let's say, then you should have a high index of suspicion that that patient may in fact have diabetes. Vice versa, if you have a fasting plasma glucose that is 130 and the A1C is 6, understand that the timing of when these children will lose their first phase response compared with their fasting response can be different. And so depends also on any comorbidities that they have. And so we like to utilize both of those values because it increases the chances that we'll be able to make the appropriate diagnosis. If there is any question, go for the 2-hour post using the oral glucose tolerance challenge. And so we do those in our building here at the Novak Center. And so certainly if you are concerned, we're happy to see the children to take care of that. And so it might be odd to be looking at a slide that's talking about pancreatic autoantibodies because that's clearly a type 1 and not type 2 diabetes. However, what we have lost over the last 15 years or so is the classic phenotype. And so upwards of about 40% of our patients with type 1 diabetes are overweight or obese at diagnosis. And that is different than the emaciated picture that that you're used to from medical school, nursing school, or training as a nurse practitioner. And that's where the child has substantial weight loss and they come in cachectic appearing. Many of these children don't even know that they've had weight loss. And so what we do at diagnosis is we go ahead and order these antibodies, and that helps to discern what form of diabetes they have, because that is a very different pathway as far as both not just pharmacologic therapy, but also what path we take when we're doing long-term monitoring for risks for other health conditions. And so the other thing we like to consider screening when you're doing this at the same time, certainly if you're dealing with a patient who is obese and you're concerned because they're also, possibly at risk for hypertension or hyperlipidemia. We tend to like to do these things at the same time. Fasting lipid panel with preference paid to triglycerides and HDL, which are a little bit more reflective when you see weight changes. LDL, of course, as far as a risk factor. And then, as I mentioned, I like to do a comprehensive metabolic profile to include those liver function studies, because many of these children already, even at younger ages, sometimes even under 10 years of age, have evidence of hepatic inflammation. Hypertension, unfortunately, is also an associated issue. And so carefully monitoring blood pressure is very important. And so, as I mentioned, unfortunately, these poor kids, we tend to pile it on. So it's the negative influence of substantial adiposity over time, and often a very sedentary lifestyle. So these children are at a greater risk for developing an array of health problems. As I mentioned, steatohepatitis, obstructive sleep apnea. Many of them are depressed as it relates to their weight. They develop eating disorders where they'll binge, or they'll try to purge, or they'll try to go on crash weight loss diets. And then, of course, as we progress to true type 2 diabetes, they have evidence of insulin resistance. And so all of these really paint a pretty significant metabolic picture. All right, so management. And so this is a difficult topic for all of us. In our age of sort of more fast-paced medicine, where we really don't have all that much time to talk with our families, we really have to get a lot of information in a very short period of time. We have been successful using different mechanisms like surveys or journals. We also will query the patients or have them fill out diet sheets prior to our entry into the room. But all of them come down to getting really nosy about their diet. And I used to be very non-specific about it. So what kind of foods do you eat? Now what I do is I say, what did you eat for breakfast today? What did you eat for dinner last night? And so I tried to match it up with what has happened in the last 24 hours, because they're more likely going to remember that. I mean, I can't remember what I ate, a week ago, and most of the kids can't. And so figuring out what did they eat for breakfast this morning can often give you a little bit of a clue into their diet habits. And that allows you to do the next steps, which is a construct for a dietary management plan. And so creating structure is the first thing. And what I mean by structure is determining when they eat on a daily basis and talking with the parents about scheduling their meals and scheduling their snacks, so that it's not whenever they want to eat, they eat. That is very big. Structuring their food intake, especially with the younger ones, is the first step that will lead to success. And telling them that they're not supposed to munch in between meals and trying to prevent that behavior will be an absolute necessity if you're wanting them to have any success with weight stabilization or weight loss. The next is starting to look at individual food groups, figuring out how to provide guidance on what types of food to eat, low calorie dense foods like fruits and vegetables, or starchy vegetables or starches. Those are things that have a lot of water content but fill you up. And so the main problem we see with that is access. And so a lot of our families with type 2 diabetes don't actually have access to a lot of fruits and vegetables. And so that's one of the reasons why you have to dive into do you have any food insecurity? And then see if there are resources available that you can tap into in order to support that move, because telling them to eat more fruits and vegetables is not going to be effective if they don't buy them. Also, altering what they do with protein intake is also big, because most of these kids have a very, very carb-rich diet. And so by altering and trying to shift the dynamic of what their food, what type of snack and meal composition looks like each day, by adding more protein in can help fill them up. It also improves satiety over time. And so they tend to be less hungry if they have more protein, for example, at breakfast. Reducing sugar-containing beverages, I hit that one every time. And that one almost always has an immediate impact, but that can be a big challenge, because you're trying to change a dynamic that it is throughout the whole household. So Mountain Dew, Coca-Cola, etc. These soft drinks are usually pretty prevalent, and so work on removing them. I also advocate the removal of all sugar-containing beverages, including juices, which is and so I focus mainly on water and skim milk and other non-sugar-containing liquids. The last thing I think is a pretty great resource is the myplate.gov. And so I put the website. It has a whole lot of options, including mobile, downloadable options that can help families actually set up profiles, and then you can set up plans within the app that you can use to coordinate this effort. And so the next step is to try to educate a family a little bit more about food. So in general, most families really don't have a good idea of the differences between fats, proteins, carbohydrates. And they certainly don't have an understanding of how each of them influences their body, which ones of them get digested and converted to immediate glucose, which ones move into storage, which adds adiposity. And so the other feature of this is that if you have a family that's already been diagnosed with type 2 diabetes, then they need to understand how all of these types of foods influence their blood sugar. Because if they do not have a meal composition that has different features to it, then you'll see pretty abrupt changes to their blood sugars. This works with type 1 diabetes as well, by the way. But what ends up happening is you have a lot of glucose variability and you don't really know how to handle it. And so by making some different food choices, what you'll see is some improved postprandial glucose values and a happier child and family. So I love this one, but this one's also a pretty tough challenge. Even creating limitations for non-school related screen time in my household is tough. But what is recommended is less than 2 hours a day. Easier said than done when many families have gotten into the behavior or habit of using the screens as sort of babysitters or sitters. And so a lot of these children who are 10, 12, 14 years old now grew up with using a screen to occupy their time. And so it is a big shift. And so you're going to have some angry kids, but utilizing this technique is a big deal, because if you prevent all screen time, and that means you have to tell the parent, mobile devices, iPads, laptops, regular desktop computers, TV, etc., everything. If they don't have that time away, then you're not going to be successful with the next one, which is physical activity. I can tell you, my son, for example, if I let him, he will literally spend 10 hours on his iPad. But the moment that clocks off, now you have to be savvy, because there are ways to get around some of these blockers, these screen time blockers. So the kids are really clever. So just make sure that they're not able to do that, or you advise the parent to be mindful of that. But when that thing clocks off and he's not able to use it anymore, then all of a sudden I see him running around and playing and so on. So So it really is quite effective because the kids will get bored. But we recommend 30 to 60 minutes or more of moderate to vigorous activity at least 5 days per week. And this is the same as what is recommended for children without diabetes. One thing that we encounter quite a bit, though, is if we provide this advice, I do not suggest immediately telling a child, go out and do 60 minutes of moderate exercise 5 days a week when they don't exercise at all. And so I give a much lower activity prescription recommendation to the family. I start off with low intensity, walks around the block 3 times a week. And then usually you can engage a parent, not always. You also have to determine whether or not their neighborhoods are safe. Is there an area where they can walk outside? And then if not, we have an array of resources that we've printed that we hand to the families that are exercises they can do inside the house without leaving the apartment or home. So it's important to actually prescribe, give them attainable targets, and give them resources that they can directly use, as opposed to just say, go outside and try to be more active. And so by being very deliberate with our guidance, with specific things that they're supposed to work on, when we have someone follow up with them, a nurse or an educator or dietitian or whomever it might be, a few weeks later, our success rate tends to be much higher. So some things that we use to try to persuade the families. Of course, we know that it's important for cardiovascular health. For type 2 diabetes or prediabetes, there's a direct correlation with improvement and often prevention of progression to type 2 diabetes. And so we work with the families to say, look, our first step, depending on where they have presented in the evolution of diabetes, often we can step in with trying to be more deliberate about our activity recommendations. And what that has done in the past is often successful, is preventing them from having to take the next step. Say if they're started on metformin, they're able to prevent having to utilize insulin right away. And so that's a big deal. Now, some risks, though, some special considerations. If you have a patient with diabetes, they are at a higher risk for dehydration related to hyperglycemia. They need to make sure that they're testing before they're active, and they need to really hydrate. If they have an elevated glucose, above 250 is sort of a generic recommendation we have for checking urine ketones. They should look, and if they do have ketones present, they should not exercise, because that basically means they're likely hyperglycemic, dehydrated, and obviously insulin deficient. Remember, ketones are produced as a secondary fuel source when the body is not able to use glucose, blood sugar, as a substrate for fuel. The other thing is that physical activity can affect insulin sensitivity. And so that can result in hypoglycemia and or even hyperglycemia. So if you have a child who is doing a quick burst of like sprints, someone with type 2 diabetes might actually see a rise in their glucose. Someone who is doing a slow jog for 35 minutes might actually have hypoglycemia because their body hasn't activated the process for which it will pull glycogen stores to raise that glucose. And so just have to be mindful. When you do exercise, you often do, if it's moderate or intense exercise, you do tap into those glycogen stores. And so you are at a higher risk for delayed, often nocturnal hypoglycemia. So just warn the families that we have to evaluate that at first. And so since hypoglycemia is a common fear for children with regards to activity, it helps to go through all these so you can allay those fears. We also advocate to be more prepared with activity, especially those who participate in sports. And so wearing your medical alert bracelet, as I mentioned, stay hydrated, having an adult present who knows how to treat lows, and that includes utilizing glucagon. The children should have on hand at the site liquid and simple carbohydrates, so both a liquid, preferably glucose tablets or some form of simple carb that can be eaten, and then also glucagon. And then they should also have an ability to monitor the blood sugars before, during, and after the activity. And so one approach that we have used very effectively is with the Christensen Family Sports and Activity Program that we have here at the Wendy Novak Diabetes Center. And that's a picture of, actually just half the room, half of our sports lab. And so what we do in this lab is we're able to personalize our approach to providing advice for these children. So we can emulate or mimic low, moderate, or intense forms of exercise. We can do anything related to cardiovascular, endurance, basically strength conditioning. We can do all of the things that they would do in normal everyday life, and we can assess what type of impact it has on their blood sugars. And then we can provide pre-exercise, peri and post-exercise insulin and diet intake and monitoring advice. And so some weight management goals. So, in essence, this particular, I pulled this resource, and I have to give credit to Dr. Sarah Watson, who helps to run our type 2 diabetes clinic and our weight and wellness program with the effort, the goal towards trying to stabilize or prompt weight loss in children who have demonstrated a very rapid weight gain over time, which obviously in general, as I mentioned before, results in metabolic derangement, including progression to type 2. And so when we think about reduction and what type of impact it has, if we see a BMI reduction of about 0.25 SDS, or doubling that to 0.5, what we see is an improvement in lowering blood pressure, improvement in lowering triglycerides, raising HDL levels, improving insulin sensitivity. We didn't see in this particular study an impact on fasting glucose, but the end result is a healthier child. And so this wasn't specific to pure type 2 diabetes. It was really geared a bit more towards metabolic syndrome. But in essence, what we want to see is a slow weight loss, and you see some different targets based on whether the child is growing or age group. Now, a safe weight loss that we talk to for the families is you want to try to create a target for them so that they have something that they can work towards. We tend to talk about weight velocity. And so a reduction in weight velocity that's personalized, that's individualized for every single child that comes into your office. And so if we have a child who over the last 12 months has demonstrated a weight gain of 1 kilo per month, then demonstrating a reduction in that weight velocity down to 0.5 kilograms per month is a success. And so that's really kind of what our approach is, because it reinforces positive behavior, and they get that sort of satisfaction that they're making progress. The reality is that it is very helpful to have a demonstration of weight loss of about 1 pound per month as a start for the older kids, if possible, up to 2 pounds. But what is amazing is sometimes simply weight stabilization can, especially if it's linked in with increase in activity, can actually result in pretty substantial improvement in their in glucose metabolism and insulin sensitivity and effectiveness. So if you are able to achieve a slow, gradual reduction in weight velocity or stabilization alone, you will often see the need to reduce any kind of anti-hyperglycemic agents that you're using, including insulin. Now, I included this in because it often is a topic of conversation. We do not currently have an adolescent bariatric surgery program here at Norton Children's, but this is a matter of debate around the country as to when you intervene. We are more supportive of considering this above 18 years of age, but these are the criterion that were published in 2018, looking at classifying obesity as class 2 or class 3, with class 3 being a BMI of greater than or equal to 40 or 140%, without even needing type 2 diabetes or any other features for comorbid conditions to consider surgery. Now, when you look at 120% of the 95th, this is what it looks like on our BMI curve. And at different age groups, 10, 12, and 15 years, that's where the BMI would be in order to achieve 120% of the 95th. And so if you just move along the curve, that's where the patients are. And so that trajectory is one that you can start to consider those things. We do not currently we're not actively working on a program like that, but it potentially could be something that we may consider offering in our community. All right, so advances in monitoring. So no longer are we using the old-fashioned journal where the kids will write down using pencil and pen in our lobby where they're trying to make up numbers, which was always entertaining. But all of these products now have the ability to download, or they have apps that can transfer data. And so we're able to utilize them very effectively to determine what the frequency of monitoring is and link that with direct management plans. In my mind, the best tool that has come about in the world of diabetes are interstitial glucose sensors. And so the ones on the far left, where that little girl is showing that off, that is approved for use in pediatrics. That interstitial glucose sensor goes on and stays on for about 10 days, and it transmits that information to some device, either one provided by the company or a cell phone even, or a smartwatch. And on the right-hand side the far right is another one that is approved in children in the US. And so that provides data all the time. And so families can share that information. So a child with type 2 diabetes can be at school, and a parent or a teacher or a caregiver, a grandparent, can actually see that information and communicate with the school if they see a problem. And so we have literally hundreds of apps that we use. Well, we don't use hundreds of apps. We have several that we provide advice that the families will use, but there are hundreds available. Many of those have some really cool food logs, or not food logs, but food diaries that or databases, sorry, that you can look up foods, including fast food and local restaurants that have uploaded this data to be used for free. And so the families are able to very effectively count their grams of carbs or see the composition of meals by using these options. And so when we think about how do we use these in the ambulatory setting, so if you're on an interstitial glucose sensor, we provide these, we're able to download them, and then we're able to use the daily downloads in order to really make treatment decisions. And it has been amazing at how effective it is. And so often we always say that for a child to have success, we have to be doing our job and they have to be doing their job, and we all have to work together. And that includes teachers and parents and healthcare providers, and it really is a community effort. And so we can identify behavior changes or resource needs that a family needs, or it's a treatment change that is required on our end. And so some advances in treatment. And so the world of type 2 diabetes is pretty vast now. So we're well beyond just metformin, which was now is closing in on its 100th year anniversary. Insulin was first successfully used in humans now 100 years ago. And so Biguanides were a close second, actually. And so this slide I like because it provides an example of all of the different targets that we aim for when we're trying to reduce hyperglycemia caused by type 2 diabetes. The top three, Biguanides, GLP-1 receptor agonists, and insulin, those are all approved for use in children under 18. And then sulfonylureas, TZDs, alpha glucosidase inhibitors, those are the next most common products that we utilize, but those are approved for use in adults only. And then the last two I highlighted with asterisks, DPP4s and SGLT2s. Those are especially SGLT2s are quite effective, and they are currently in the pipeline. And so we have been participating in type 2 diabetes research in children and adolescents with these class of drugs. And so what we hope is in the next couple of years, we'll have some more options. So when we're talking about how to make a decision about what options to use, we start off usually by getting that history, determining what kind of dietary or activity changes might we be able to make. And then we look at what are the current glucose values and what's the A1C. What are our goals? If you have an A1C that is 9, 10, or higher, then typically we start off with insulin, and that's using a basal insulin. First line therapy for us is usually glargine or degludec. Multiple daily injections we used for some analog insulin, and we'll treat them often in a very similar fashion to our children with type 1, where we will come up with an insulin to carbohydrate ratio, an insulin to glucose correction factor, and come up with a simple math model for the family to use for each meal. If they're not capable of doing that, then what we'll do is we will come up with not a sliding scale, but a more set dose. Some of our patients are on insulin pumps, and so those are the ones that require a lot of insulin in order to get the job done, or they have failed on other anti-hyperglycemic agents. For medications, I mentioned metformin and GLP-1s are really the only other ones that are approved for use in children, and we'll go into a little bit of detail about those here in a moment. So insulin is done either the old-fashioned way with syringes and vials, or our preferred way, which is using insulin pens, where you screw on the needle onto the tip and you can dial the dose. And those are quite mobile and very effective. And then insulin pumps, we have two different types of pumps, tubed pumps or patch pumps. Both of them are used in type 2. One limitation we have is the quantity of insulin that is able to be put into these pumps. And so since we're working beyond this to try to override the insulin resistance, and in most cases, these patients are able to produce a lot of insulin on their own, they need a lot. And so what you find more effective is the tubed pumps, because you can refill the cartridges more easily in a quicker turnaround. Now, hybrid closed loop systems, while they do function a lot better for type 1 diabetes, we do have some of our kids with type 2 that use them. And so closed loop hybrid systems, or hybrid closed loop systems, are where the interstitial glucose sensor communicates with the insulin pump, and the insulin pump, through a sophisticated algorithm, is able to increase or decrease the amount of insulin that's being provided. You still have to have hands-on management with the pump. You still have to input data, but it does help to smooth out the edges. And so it's been a very effective tool for us. What we hope is that we'll see more research in this area for type 2, so that it'll be a bit more effective for those kids. So going to metformin. And so metformin comes in a variety of dosing options, 500, 750, 850, and so on and so forth. But we tend to go with the lower dosing initially, starting off with a 500 milligram dose given either at breakfast or at dinner initially. And we always tell them to take it with a meal, preferably when the meal has already been started. I also will periodically advise using a probiotic. There have been a couple of studies that seem to suggest some people have a lower GI side effect profile when that's used in conjunction. And I don't have a particular one that I try to use. It's just whatever they can find that they can afford. But the way this works is it reduces hepatic glucose production and has some influence on improving insulin sensitivity. And then it decreases absorption of glucose from the GI tract. Now, the GI side effects typically are abdominal discomfort, nausea, or loose stool. And the loose stool is the thing that seems to be the side effect that prevents people from staying on it. And so try to provide that guidance at the very beginning so that you have a greater chance of success. So probiotic, making sure they're taking it with the meal, huge, especially with the meal part. Now, GLP-1s, I love this drug class. It has been a wonderful addition to what we're able to use for the kids, and a lot of them are able to reduce their overall insulin requirements, some of which have been able to come off of fast-acting analogs and only use a long-acting analog, like Glargine or Degludec, as I mentioned. And so the way these work is they literally affect an array of targets. They improve satiety, they reduce gastric emptying, so the stomach feels full, so the patient tends to eat less. They are able to improve insulin production and preserve the beta cells. And then the last thing that we see is a reduction in glucagon secretion. And so that influence on the postprandial rise that results from that glucagon is a very big deal. And these GLP-1s are able to prevent that. And so the two different choices, liraglutide and exenatide. So both of these products are on the market and approved for use in children 10 and older. One of them is a daily and one of them is a weekly. We tend to use the daily. It's usually the one that gets approved more easily. Cost and insurance coverage is our biggest enemy for these children. One thing that many of you all may actually know is that liraglutide was approved for use as an adjunct for weight loss in 12 and older. Full disclosure is if you do this by itself, it's not terribly effective. So if the child thinks that they'll lose a whole bunch of weight just by taking this and they don't have to exercise and they don't have to change their diet, unfortunately, it doesn't work. So we stress that it's an adjunct, but it's the other reason why I like to use this in patients with type 2. Because in patients that work with us to change behaviors, eating behaviors, they do actually notice this satiety difference. The side effects are actually minimal. In general, while we do have to reduce their insulin utilization if they're on these products, and that's actually a win, it's rare for us to see hypoglycemia if we're using this all by itself. And so last thing I did want to mention, hypoglycemia treatment. So these are new on the market. And so all patients with type 2, all patients with diabetes should have a glucagon prescription, and they should have that on their person. We tend to have one at home, one at school, and then one that they carry around. If they live in different households or they spend a lot of their time with their grandparent or a family member, just make sure that they have a prescription at that home as well. And of course, we do that as a matter of course through the center. But that one is a nasal formulation and is just as efficacious. And the one on the right is one that's pre-mixed. And so we went from someone having to fumble two different things, mixing it and then drawing it and then giving it, which you can imagine in a panic situation doesn't work very well, to these products, which has been another game changer. So I have to do some shameless plugs of our diabetes center. So we have 9 physicians in our group. One of them, Dr. Lisa Folsom, is a med-peds endocrinologist who has been wonderful in helping us with our transitional age group. So these are those children that are 18 to 26, especially effective when many of you who keep your patients up to 21 or sometimes a little bit longer, we're able to provide those services without sending them on to into the adult world. We have 7 nurse practitioners that are fantastic, 3 pediatric endocrinology fellows, and then a huge patient and family support team. You notice dietitians, nurses, diabetes educators, licensed clinical social workers who also provide some behavioral therapy. We have a child life specialist and a fantastic diabetes research team that does basic translational and clinical research for our kids with type 1, type 2, and other forms of diabetes. And so in our Wendy Novak Diabetes Center, we have type 2 diabetes multidisciplinary clinic, and these kids have opportunities to participate in a variety of research trials, which simply participating provides them with more resources, and often we're able to see wonderful outcomes. And then we also have a weight and wellness program that I wanted to make sure I shared with you. This is an evaluation for endogenous causes of obesity, and we have extensive nutrition and activity education that we're able to provide these kids. And I wanted to thank you all for your attention, and I'm happy to entertain any questions.
All right, thank you, Dr. Wintergerst. Some questions here. Can you review the locations in Louisville for oral glucose tolerance tests, and can a pediatrician order this as an outpatient lab?
So as far as specific locations, many of the outpatient labs, the facilities we have at Norton Healthcare actually can perform those. We perform them in the Novak Center for Children's Health, and they are able to perform them at the hospital locations. Actually, we did used to also be able to do them at Norton Brownsboro, Norton Children's Medical Center. I don't know if Dr. McDonald, if you recall whether they're still able to do provocative labs like that at the medical center, but in the past they have been able to.
Yeah, I'm not sure about that.
No, but we can look for, yeah, we can check on a list. That's a great question, and so we can look up a list and then find some mechanism to share that with anyone who is interested.
All right, obesity seems to be worsening significantly since COVID-19. How often should pediatricians screen for type 2 diabetes?
So that is an excellent question. And unfortunately, we are seeing that as well. One other factor is that there is with COVID, so we take 2 different issues here. One is the isolation that has increased sedentary behavior, and it also has drastically increased behavioral health issues, so depression and so on. Eating behavior has been completely skewed since these kids for a lengthy period of time were able to sit at home and eat whenever they wanted to. But one of the other features that we are also anecdotally seeing is an increase in both type 1 and type 2 diagnosis that we do not think is simply because of that change in sort of isolation and activity behavior. And so COVID alone may indeed have an influence on an inflammatory cascade in affecting the pancreas. And so we're part of a multi-center research trial that is going to be investigating this. And so just food for thought. And so we may find out that there's more to this than just that change in behavior. As far as monitoring, I recommend annual screening for those that are at high risk. However, if you see a patient that has demonstrated rapid weight gain, or they have other comorbidities, so like hypertension, for example, I would suggest, even if you screen them and they're normal, bring them back at least at the 6-month mark to determine if they have continued to gain weight substantially. And so even if those initial tests are normal, if they have shown significant weight gain and they are high-risk individuals, a repeat at the 6-month mark is appropriate. Okay.
Should pre-diabetics be referred to you all?
My thought is in general, yes. And the reason is because The diabetes team that we've been able to develop at the Wendy Novak Diabetes Center is able to take the time to work with the children, both for dietary exercise, and then we're also able to more closely follow them when we intervene with some type of therapeutic intervention. And so we realize that most practices do not have their own dietitians or social workers or diabetes educators, of course. And so if you have a child who has prediabetes, you can start off, if you wish, if you feel confident that the family would be able to make some type of headway with weight stabilization or weight loss. Certainly you can try to see if they're able to accomplish that, but we're happy to take that on.
Okay, is there a magic number of A1C number that we can start metformin in obese kids?
In general, in the past, we attempted to use metformin before a diagnosis of diabetes. And so when we had a patient with, say, an A1C of 6%, when I showed you the criterion for A1C for the prediabetes state, you're starting to talk about A1Cs of 5.7, 5.8 and up. If you try to intervene with that metformin that early and they have a side effect, it is really difficult to get them on it later. And so I would suggest that your metformin use be held until the A1C is either just approaching that 6.5 mark or has just barely breached it. Because otherwise, like I said, the side effect profile, they sort of have this therapeutic memory to them. And if you tried it when they were at 5.7 and they stopped taking it and then they progressed and they're 6.8 now, they're like, no, not even trying it, even if they didn't do all the things that we counsel them on to reduce that side effect profile in the individual.
Okay. And are there any programs similar to our past U of L Healthy for Life program that we had? Anything in the development?
Yes, so that is also a great question, because the resources needed to have a true weight loss program are extensive. And as we know, typically, or the Healthy for Life existed because there was substantial insurance support through Passport, so literally grant support in order to underwrite that operation. For us, we have developed our weight and wellness program that is an entry level for that. We're able to provide preliminary guidance, and we're able to monitor those kids. However, we don't have quite the resources that Healthy for Life had. We are looking to coordinate a multidisciplinary, multi-service line specialty effort with general pediatrics, cardiology, and others here at Norton Children's. And so you should expect to see that in the future as these programs evolve. So the answer is yes, it is coming. And if you have a patient that you're concerned about, please feel free to refer them to our weight and wellness program.